Hi everyone. Today we have an amazing guest and we're super excited about this interview. But first, I'm going to ask Sergey to remind you a very important thing.
Yes, please like our podcasts, our recordings, and subscribe.
You heard the man. Please do that. And now I'm super happy to introduce our today's guest. His name is Shiv Rao, CEO of Abridge. Hi, Shiv.
Hey, great to be here. Thank you so much.
Let's start with kind of your short background. I know you have a lot to tell, but people are following you for a long time. So maybe you can just say your background in a couple sentences, but also add more about your hobbies so people kind of know who you are, not just as the CEO of Abridge, but also like what are your hobbies, what do you do, what do you prefer?
Awesome. Yeah, we love that. I'm a cardiologist, still practice, see patients about 1 week in a month. We were just talking about this. But I'm in technology. I'm the co-founder and CEO of a company called Abridge. We started the company in 2018. Prior to that, I was a corporate investor and led innovation for a large health system in Pennsylvania called UPMC. I joke, but it's very true. I say this joke all the time. I should stop. But I sort of violated Peter's principle like 10 times in 5 years to get to that role. And it was an incredible privilege. Got to learn from a ton of people around me, and analysts and designers and engineers and product people. And it was just awesome. I just got to osmotically absorb. One of the things I got to do was invest into Carnegie Mellon University. We started a machine learning and health program, and there I got to osmotically absorb from professors. We were funding their research, their labs, and that was really, really exciting, especially at that moment in time with deep learning starting to take off. One of the people I got to fund is someone named Zach Lipton, who's a professor at Carnegie Mellon, who's building Abridge with me as well. A couple lifetimes ago as a kid, I went to Carnegie Mellon. I studied a lot of what I'm not doing today. You can't go to Carnegie Mellon and not do a little bit of technology. So I did some of that. I was programming virtual synthesizers in the School of Computer Science and School of Fine Arts, but I was a history major. And I studied minority studies and I studied film theory, and I got a scholarship here to do a lot of stuff that was sort of off the grid at the intersection of art and technology while I was doing pre-med requirements, because I realized pretty late I wanted to be a doctor. But anyways, I'm really into all things related to just how technology affects culture. I'm interested in art and design. My wife was a designer and a teacher of art education as well, and so there's a lot of that in our household. But otherwise, things I like to do on the weekends anymore, it's just Claude Code with my twin 9-year-old boys. That's their new obsession. We just build Pokemon websites anymore, apparently, but I'm an expert at that.
Nice.
But yeah, it's
maybe your next company.
Yeah, absolutely. Maybe they can start some Pokemon card trading website. We'll see.
Awesome.
I was curious. I was reading about things you did before you became a doctor, and like when I guess your Indian parents were like disappointed at you, like you're Dijan.
Yeah.
Just tell us about like that part. Like I think there was like something in the news, but maybe just from your own story. Like, what are you doing? Maybe you didn't even mention something before that. Your interest with like various things you were involved with, like just like as a in your like youth, I guess.
Yeah.
As you were growing up. Yeah.
Yeah, absolutely. Well, I mentioned I studied a lot of things that were sort of off the grid at Carnegie Mellon University. It was an amazing time for me, and I think in some ways I was probably subconsciously rebelling against all the Indian doctors in my family. My dad is a cardiologist, or was a cardiologist. I have a sister who's an infectious disease doctor. Really, like, there's just doctors and clinicians. I have another sister who's a psychologist. Just a lot of medicine in the family. And it's a trope, like there's a lot of Indian doctors in the world. And so I really wanted to go against the grain and figure something else out. And so I was able to pursue a lot of interests and build up a lot of passions for a lot of different things, like over the course of undergrad especially. But there was an architecture professor when I wanted to be an architect who convinced me, William McDonough. He sort of visited Carnegie Mellon University and gave this lecture about how we're all designers of the world. And this was when the D School at Stanford was pretty young. And he told a story about this ophthalmologist who had designed this revolving platform, and he sits on it and he does cataract procedures at 12, 3, 6, and 9. So he sits on the revolving platform, does a cataract, at 12, and then he says spin, and they spin him to 3 where there's another patient waiting, does 3 and then 6 and then 9, and they bring these patients in on double-decker buses from the villages, and it's pay as you can, so essentially free. So by the time I heard this lecturer, this ophthalmologist had given eyesight to over 1 million people, and his daughter had given eyesight to over 400,000 people, and I remember thinking like, okay, actually, I really want to be a part of that kind of impact at that kind of scale. And so that was the start of my sort of pivot to being a doctor. Thankfully, my parents never celebrated. I probably wouldn't have ended up doing it if I thought I was somehow kind of like going back into the fold. But it was good.
I was curious, there are like certain stories like how the name Abridge came about.
Yeah.
Like, is it related to like Pittsburgh Cedar Bridges or just like bridging?
Yeah.
AI and healthcare, like how did it come about?
Totally. I think it first came from thinking about the product and how we're trying to distill. We're trying to take a lot of complex information and distill the essence, and we're trying to abridge, and sometimes we're abridging longitudinal patient records. Sometimes we're abridging, policies. Sometimes we're putting a lot of different, seemingly disparate pieces of information together and coming up with something that could be really, really helpful and really easily digestible and understandable. And we're also aspirationally trying to build a connection between the most important people in healthcare. There's the clinician and there's the patient. So there's that connection there. And now I think the way we think about it increasingly over these last few years is how do we build a bridge and a connection between all the stakeholders in healthcare. So thinking about providers and payers, for example, or even life sciences companies, and there's such an opportunity there, but really it all starts with the end users. But then finally, you're 100% right. We started this company with a lot of cardiac ML and DNA in Pittsburgh, and Pittsburgh is the city of bridges. And so, a lot of different meanings to it. It served us well.
Nice. I guess I started talking about this, but in terms of your product, you mentioned that it's every node is a bill. I think like for non-medical people like myself, when somebody says AI scribe, I'm thinking about like summarization, helping handle the node. But you're thinking a little bit, I think, differently. Could you just talk about the process? Like, how do you think about your product?
Yeah, absolutely. So I'd say for years we've almost categorically, maybe like there have been a couple exceptions over these last 8 years where we've tried to avoid the phrase AI scribe. We've tried to make clear that our thesis really is about people, and it's about what they're doing, which is having conversations. We truly believe in the next 10 years still that we're not going to fully automate all the doctors out there. And if that's the case, then when we're really sick or when our loved ones are really sick, they're probably going to see a clinician. Hopefully that clinician has access to AI superpowers and could do that much better of a job for us, but they're still going to be around. And if that's the case, then how do we interact with them? We have conversations like this, and those dialogues oftentimes are upstream of so many of the workflows that come next. And there's any number of different workflows. And the workflow that's served as the wedge is what you described. It's documentation. And so it totally makes sense that there's a whole category around like scribing, and people talk about documentation as if it's like the be all and end all, but it's not a dead end. It's only one of the different tasks that we can kind of go after over time. And so as you start to thread the needle or pull on the string, to mix as many metaphors as possible, but if you start to pull the string, then you realize, well, conversations are upstream of not just clerical work like notes, but also clerical work like order entry, like diagnosis codes, like claim creation, like risk adjustment, like fee-for-service revenue cycle, like clinical trial recruitment, like patient education, and the list goes on and on and on and on. So it's this leverage point, and it's upstream. And so what you do in what order matters. And I think a lot of folks realized, well, documentation is probably the first thing you should do because it's such a pain point, and it's such an incredible sort of vector into those next use cases. But what you mentioned about bills is important to kind of acknowledge, which is that in this country, we're not compensated for the care that we deliver. We're compensated as doctors for the care that we documented that we deliver. What is in your note will determine whether you're in a value-based care contract and it's all about HCCs and being able to capture the complexity of the patient that you're caring for, or if you're in a fee-for-service world, these notes matter so much. They need to be concordant with the claims that are created. They need to be consistent. They need to reflect all the care that was delivered. And we're in the moment, in the conversation with the ground truth of what care was delivered. So we have such a great sort of opportunity to create, truth, in relation to not just what was delivered from a care delivery standpoint, but also from a revenue cycle and reimbursement standpoint too.
I want to talk about tech side for a little bit. As you mentioned, you started Abridge in 2018, already working with transformer models, ChatGPT and all that fun stuff. Fast forward today, are you still working on your model, or are you using one of the foundational models or many of some of the foundational models? Because there's so much money poured in those models, at an amazing pace they progress. So the current solution is based on a foundational model or your own model?
Anymore, it's all about model orchestration. So we started with pre-trained models that predated LLMs like BERT, BioBERT, Longform, or Pegasus T5, and then LLMs became a real thing for us, I'd say in 2022. I remember in 2021, we had access to maybe GPT-1, and I remember the last slide of a board deck that I created was some GPT-1 sort of blurb in my voice, and it was awful. And it was just sort of like helping everybody understand around the table that we've got our finger on the pulse and we're tracking this technology, and we'll demonstrate, we'll absorb it and figure out how to build on top of it or beside it when the time is right. The time became right, I'd say in mid-2022. We'd gotten sort of advanced access to GPT-3, and you could see it immediately. Like, you could sort of see the future and what was going to happen, and it was incredibly exciting. But by that time, we'd already published a paper in late 2021, and we presented it at conferences like ACL and others, and won a lot of awards for it, where we demonstrated, even with those other models, if you had enough money and enough training data, enough annotations, you could actually create a pretty good approximation of a clinically useful note that clinicians would even pay for. And so we had something that sort of, and we had a lot of work and a lot of time and space behind us that sort of gave us an idea of what the future playbooks would be. Because even post LLM, the playbooks are still fine tuning. Perhaps you don't need armies of people to create data annotations. Perhaps you can do things in way more clever ways and scalable ways, but fine-tuning is still a big part of our playbook. Distillation, is still a part of our playbook. Being able to post-train and learn from all the edits. Now that we're at scale, the edits that doctors are giving us across all the different specialties every day, we can use those in post-training and then create better notes for all those individual specialties or even like clinicians. And so how do you get at that kind of level of to me, like magic for the end user? You need to own and control as much of the stack as makes sense. But this is where there's a really important strategic decision. What makes sense to own and control? And if, in my estimation, if there's a part of the product that you'll never be perfect at, and that you'll always aspire to be less than perfect at, you might be better served actually thinking about partnering with frontier models, but building on top of them all of the harness, that as we call them anymore, all of that work around, tools and memory and guardrails and like the data that you need to context engineer, focus there instead of necessarily like the core frontier model, but build all around it. And that harness ends up being your differentiation and what differentiates like your core output versus anyone else's. But there are also other aspects of your product where you're going to be able to ring the bell pretty quickly, where good enough you could see it. And you can you can also sort of anticipate like hill climbing to good enough to 10 out of 10 relatively quickly. Well, there you should go after, own your destiny, like build that model yourselves. But you're going to need a certain variant of talent. You're going to need a certain amount of training data, and you're going to need some sort of like loop, to do that sort of reinforcement learning and like the post training. And so that's how I think about it strategically. I'd say that said, when you have a company filled with really technical people, you can get even more ambitious. And so at this point in time, maybe 70 to 80% of what we do is all in-house, driven by in-house models, and perhaps like 30% of it has like a frontier model, associated.
Got it. For the orchestration, are you still trying to use one model for generation, one for auditing, one for validating, or how did that work?
Yeah. Yes. Like long story, yes. Like I think short yes is like, you in the new world that we're in, the ability to have, imagine like sub-agents doing different tasks in parallel to get the ultimate job done. The same way, my kids and I use Claude Code over the weekend, and sometimes we have 5 terminal windows open. We go to bed and we wake up in the morning and like a job got done. Oftentimes the job isn't gotten done like the way we want it to, and then we have to go back to the drawing board perhaps. But there's a QA agent who looks over the work that we're doing. There's another agent that's sort of like a judge, related to QA. There's another one that's maybe like taking a part of the job and decoupling it, unbundling it, and all the different tasks, and operating like a program manager for, software engineering agents to go after the work. And so similarly, if you think about the clinical work that happens in an outpatient setting or an inpatient hospital, there's so many different tasks. And all those different tasks that clinicians have to do, you can kind of prioritize which are the ones that are lower stakes, maybe not decision support, not going to impact a patient outcome very directly, more related to clerical work. And those lower stakes tasks, let's go after them one by one by one. So there was an American Journal of General and Internal Medicine article that was published a couple years ago that suggested that doctors need, I think, like 27 to 30 hours a day to get all of their work done. And you reconcile that with all of the people out there who are like, we're going to fully automate doctors. But doctors do so many things. To automate the entire role is different than automating some of their tasks, and we shouldn't conflate the two things. And so in terms of tasks, which tasks should we do? And that's where we come in. Our idea, our aspiration is to go after all of these tasks over time so that doctors can ultimately like live out their values, the values that took them to med school and to nursing school. For nurses, like the values that are all about delivering the best possible experience and the best possible outcome.
And kind of to wrap up this part, that part that is based on the foundation model, when they have an update and a newer model comes out, and even if we look in the future, a newly superior model comes out, how hard would it be to switch from older one to a new one? Is it like days, weeks, months?
It can be days. And we actually measure that inside the company because it's a reflection of our agility and our ability to sort of ride this wave that we're on, and to be intellectually honest with ourselves about how good our product is, and to be honest with the market, about how good our product is. There are certain parts of the stack where it moves less quickly. Speech recognition, for example, doesn't move quite as fast, and it made strategic sense for us to completely own and control that early on, because there are new drugs that are coming out all the time. Doctors don't know how to pronounce any of these drugs. I don't know how to pronounce any of the oral oncolytics out there. There's 25 different ways to say metoprolol, a very common beta blocker, medication for blood pressure and heart rate in cardiology and internal medicine, general medicine. And so keeping up, with and making sure that we can meet people wherever they are is a treadmill worth running on completely ourselves. And so that's where we have multiple speech recognition models that we orchestrate together. They're all in-house. They've all been sort of fine-tuned. They're orchestrated together to create the best possible transcript that we can. And then from that transcript, we create notes and we create all the different artifacts.
So, our very first episode of this podcast was called "Why the Hell Do We Need 126 AI Scribes?" And I looked at actually many of them. For some I used somebody else's reviews, but to me it's just such a massive overlap, like very similar products, like almost like copycats. Obviously you've done very well in the space. So I'm just curious, what do you think in your view, what differentiates you? Is it, have like linked evidence feature, other cool features? But is that what differentiates you from everybody else? Like all those 125, I guess, scribes that I counted. what's your view on that?
Yeah, oh, that's amazing. I'm just like mind blown by that number. I think that there's, with all the respect in the world, because I think you would agree, we want everyone to be innovating right now, especially innovating in healthcare, because healthcare deserves it and healthcare needs it, and healthcare needs all that creative energy. Healthcare also needs, responsible deployments at scale that can create real measurable impact, and it needs rigor, and it needs trust, it needs science, but it needs innovation. And so the more the better. I wish it was a bigger number. At the same time, it's really easy to create a party trick right now, and it's really hard to create an enterprise-grade, trustworthy platform. And when I think of party tricks, I think about what my kids and I are doing over the weekend with these cloud code experiments. We can create one of these things and these ideas. Like, I've built my own version of Pocket. Do you remember Pocket? It was this app where you could save articles you were reading, like, or links, and all your articles, you can annotate them a little bit, and you could save them in one place across all your websites. It had a mobile app, it had a Chrome like a Chrome plugin as well, and it was just like really seamless. And my brain lived on Pocket, but then Mozilla bought Pocket and they turned it off. So I was without my brain anymore, and I'd been waiting for someone to build something like Pocket that had all the features that I became addicted to over the years. So I built my own, and it didn't take much time, like probably like 7 or 8 hours on a Saturday. And by the end of it, I had a Chrome plugin, extension. I had a mobile app, I had a web app, and it's all working seamlessly. And then, it's using like it's like a pretty, very, very modern sort of back end, using like semantic search, with Turbo Puffer. I'm like tasting all the latest and like most exciting technologies. All of that's in this stack. It's working, and now I'm sharing it with other people as well. That's the moment we live in. Now, the difference between that and something that can truly scale is its own thing. But in this new world, it is so important that it's easier than ever before to build these things. And that's why we're seeing the market react the way it's reacting to, like there's this SaaS apocalypse, or the SaaSacre, or whatever they're calling it these days. So when I think about healthcare, what I see in relation to our space specifically, and I think maybe what partially explains like some of our success and the privilege that we've been able to earn over these years, is that in healthcare, regulated, trust means everything. Credibility, transparency means so much. These are high stakes workflows, even if we're doing clerical bits at first. The ability to demonstrate that you can scale to all the different use cases, because once you see a cardiologist, for example, you haven't seen every cardiologist, and you certainly haven't seen an oncologist's preferences yet. So there's a lot of work to be done, and will never be perfect. Yeah. And it's a sort of wedge into a way bigger, it's like sort of opportunity that we were talking about earlier, like how we can really impact all the different aspects of care delivery over time. So I think that it's a exciting moment right now, because the barrier to entry to build anything you want is lower than ever before. At the same time, for certain industries, for certain use cases, where there's a huge opportunity to create impact that you can kind of quantify over time. And especially if those industries are difficult to get access to proprietary data sets or to integrate, and where they're regulated, you've got a huge opportunity for companies to be created. And so that's why I think we've seen certain companies inflect in healthcare. We've seen certain companies inflect in some other vertical industries as well. And why in like the consumer spaces, if it's 126 in our space, there's probably like 10,000, for any given category out there. And that'll just, become more and more profound over time, I think.
Yeah, I want to shift gears a little bit and talk about investments. You've raised, I think, close to 800 million so far, which is insane. Congrats. But my question is, I feel like when we hear all the valuations right now, I think they're a little bit overhyped, even starting with OpenAI and others. I think yours right now is somewhere around $5.3 billion. Andreessen Horowitz and other investors, are they seeing something, and do you see something that general public doesn't see to kind of validate that valuation?
I think that certain, long story, yes, like they have to do their work. They didn't sort of vibe on, underwrite like the valuation that they believe in. And so the investors that we've had the privilege to work with have done their work. And I think the most important thing is that they believe in where we're going. They believe in what we can build over time, and that they believe that there's a pretty historic opportunity right now. Right now, to give you a sense, we're live in over like about 250 of the largest health systems in the country. We are serving all the different clinicians and all the different specialties and all the different settings. We'll touch well over 80 million sort of people, like lives, like in this next 12 months. And hopefully we'll get to 1 million a day this year. We think we can get there. So there's like some scale there. And when you think about how we kind of got in to create like this impact, yes, absolutely. It started with notes, and we'll always be building better notes for all the different doctors and specialties and settings and spoken languages. We'll never stop. But we've also earned the right to now expand beyond. And so over this last year, for example, we've been able to demonstrate it was really never about the note. It was always about the interaction, the conversation. It's about care delivery. Last year in the summer, we announced a partnership with a regional blues called Highmark in Pennsylvania, where we're doing prior authorization at the point of the conversation itself. So instead of the doctor talking to the patient, realizing they need a sleep study, and then placing the order for the sleep study, and then 3-4 days later, themselves or a staff member calling the insurance company to justify why the patient deserves a sleep study, and then filling out a long, sheet of paper, 2 or 3 papers with pencil and pen, and faxing that to justify the sleep study to the insurance company, and then waiting for back and forth, and finally getting approval perhaps weeks or maybe even months later, and the patient is now at home waiting for this study that could potentially change the trajectory of their health. Instead of all that, doctor talks to patient, technology hears sleep study, technology now in the background pulls the patient's medical records that are relevant to a sleep study, understands that this patient has a specific insurance in a specific geography, pulls those prior authorization guidelines, all still in the background. Doctor doesn't need to know any of this is happening. Then the doctor hits stop and it says, hey Shiv, this patient in front of you has this plan in this geography. You just decided to get a sleep study. There's 2 more questions that you should ask based on all the data in their chart and all the data in your conversation. If you ask them, we will give you the approval right now, because the insurance company has given us the ability to do that. So we just sort of compressed so much of the bloat in healthcare workflows, and we've shifted it all left, all upstream to the actual moment that matters the most, the sacrosanct moment where the professional and the patient, where the actual value exchange is happening in healthcare. Everything else is an abstraction. Everything else to me on some philosophical level is sort of, it's a lot of it is bloat. You know what I mean? Like what really matters is what happens when those people are together, at least, as far as care delivery goes. And so shifting as much of that into the background and as far left as you possibly can is a really powerful thing, we think. And so that informs, I think, how we get, we've been able to get so lucky, with great investors and raise a lot of capital, because there's just so much to build, and we can do it so quickly, especially right now.
Talking about investors raising close to $1 billion, how much power do you still have, you and your team, over like decision making in the company? And were there any situations when like your vision kind of is a little bit different from investors' vision and they're trying to push you a different direction, and how do you deal with that?
Yeah, I think that oftentimes investors have a thesis already, and they're prepared minds. At least a lot of our main investors were very prepared minds about our product, which is always great. When you walk into a room and you're talking to an investor and you're so hive mind that you're finishing each other's sentences, it's a pretty magical feeling. And we've had that experience with a lot of our investors. In fact, our earliest investor is here in New York City, Union Square Ventures. And remember when we first met Andy Weissman there, he'd actually emailed an advisor of ours saying that he was looking for a company like ours that had the same sort of vision. At the same time, Andy, even if he had the idea, he didn't start the company himself. And so they're looking for people who they can trust, at least the investors that we've decided to pull onto our cap table are looking for people that they can completely trust in sort of taking the company where it needs to go. And that's a rare variant investor. I'm not saying that's every investor. It's a rare variant of investor, but we've had the privilege to pull them in. So in terms of agency, in terms of control, in terms of like how we manage the business, we set the scorecard, the report cards for what a win looks like. So if we decide at the next board meeting, a win looks like this new feature being able to pass, this number of LLM judges and also this number of human judges before we deem it to be kosher to actually ship at scale, that's our report card. And then our board's job is to hold us accountable to the report card that we defined, that we created for ourselves. And that accountability, that sort of governance at other levels as well, is really, really valuable. And I really believe in. But in terms of where we're going with this company, we have 100% full control. And that's super important to me because this is a long journey for us. When you start to raise this amount of capital, you've burnt every boat. This is about like ride or die, trying our best to build a generational company and have the privilege to create impact at real scale like that ophthalmologist. And that's going to be a decades-long journey. And so we can't have people around the table who are optimizing for the lowest hanging dollars, because in healthcare you can find lowest hanging dollars, but oftentimes they don't lead to the actual profound outcome. And even more often, you need to take many showers every day to feel good about those dollars. So yeah, I think in terms of how we've managed that, I think I wouldn't do anything different in terms of the capital that we've raised and who we've raised it from, most importantly.
I love it. Talking about long journey, can you tell us if you're already thinking about IPO? Because Sergey wants to buy shares in the secondary market already. Should we wait IPO anytime soon?
I got really great advice from Henry Kravis, who's also on our cap table from KKR, who sort of invented, VC as far as I'm concerned, like 2 and 20 and everything. And I remember when he's a more recent investor, and when I sat down with him initially, he asked me like, so you want to IPO?
What's the exit strategy?
Yeah. And it was actually a trick question, because I told him, yeah, I see that in the future at some point. He said, no. Why do you see that? Like, you should just be focused on your mission. And if you need capital from private markets to get at that mission, you take it from the private markets. And if you need to go public in order to get to your mission, then you'll go public. But otherwise, you should not be thinking about it. You should just be thinking about what you need to achieve. And right now, at this moment in time, we don't need to go public. And we can continue to get what we need, and we certainly have it more than enough already right now to sustain us and sustain all the R&D, most importantly, that we want to invest against over many, many years. And so it's not on my radar, it's not in my head. It's not how we're recruiting or building a team. But as soon as it becomes something that is necessary for us achieving our goals, we'll definitely do what we need to.
I feel like it's a usual trend right now. A lot of companies stay private for a really long time.
Yeah. I think there are reasons for that too, but I'm not going to get into that.
Yeah.
I'm actually going to ask one more question on that, since I'm kind of curious. I'm going to be critical.
Great.
Some companies in the space like health tech I looked at, and I don't know, maybe it's an unfair criticism, you tell me, but when I see especially customers that are big customers that are making big decisions for a company or a startup, and at the same time they're also investors, to me sometimes that creates perverse incentives, like and I actually noticed that. I'm not going to mention names, but an incentive is obviously you want to get to high valuation as an investor, but as a customer, what do? So some of these companies, they play some accounting tricks. Like, I'm not saying everybody's doing it, but it's kind of the incentive, because you're kind of on both sides now. So you're maybe you're booking revenue that's not there yet, maybe, things like that. I'm not saying it's happening here. I'm just saying, just sort of like rationally, obviously, as an investor, you want to get to high valuation. As a customer, you kind of saying, well, I'm also an investor, so I kind of know what to do. And so, I don't know, the incentives to me sometimes could be a little bit off. Again, I'm not criticizing, and I guess there are situations where customers are investors, and that's okay. But I'm just curious about like your opinion on that.
Yeah, I think from my vantage point, strategics play a very specific role on the cap table. We've never had a strategic lead around, and perhaps if they're leading the round, then they're setting the price. And depending on who that strategic is and where they actually make their money, perhaps there could be, an incentive to do what you were describing. Chances are, from any of the credible strategics, these investments actually don't do a thing to their P&L. They usually end up being someone's side project. Like, hey, let's go see if this makes sense. And it's more from the standpoint of M&A. When strategics like that are participating, the strategics who could lead, I think oftentimes are doing it from an M&A standpoint, because this could become something that we need to absorb the threat of, and we'll be able to pull an amazing team and product and sort of business right in. And if that's the case, then it's going to be the other incentive to actually bring that price down, because if they're looking to buy this, they want the lowest price, obviously. That's when they turn very adversarial, obviously.
Yeah.
So the way I think about strategics is, they should always be minority investors. They should not be directors who can sort of inform, the trajectory, because it has to be very difficult for them to decouple their own business's interests from our company's interests, which are to serve all the business's interests out there that we can serve, all the different health systems, for example. So, that said, when a strategic can be a small investor and there's a value like exchange, there's a trade around being able to innovate together in a really deep way, being able to give the company access to feedback loops, compress cycle time. Speed is everything in software. Then it's incredibly valuable. And that's something I'm more than happy to acknowledge. And that's how, at least from Abridge's standpoint, you can earn the right to even having a conversation around making an investment. But even when you make that investment, it's going to be a small investment. And that is as much about giving them that return for giving us this feedback loop cycle, as it is for, psychologically giving them that skin in the game, hey, we're in this together.
Yeah.
So we've had a lot of strategics invest over time, and, they've been incredibly valuable for us. We've had Kaiser, for example, Kaiser Permanente Ventures, which, by the way, is, it's like a separate entity, compared to the system, even if they talk and obviously share notes, and they're very aligned and in sync. And we'll probably look to bring in more strategics, honestly, over time. But the criteria that we have for who gets to be on our cap table and be in the room is very rigorous, and we won't violate that. I speak as someone who used to be a corporate VC at UPMC, and I've certainly seen what can go really, really right, and also where sometimes it can go off the rails.
I knew there was a rational explanation to my question.
Most of the times there is.
I had this Substack article some time ago called "Doctors Go to Jail, Engineers Don't," basically about liability that a lot of clinicians in this country are concerned about. There's a lot of excitement about AI, but there's also if AI does something, who's responsible? Yeah. And with regards to clinical notes or AI notes, when I talk to some of my colleagues who are doctors, they express this concern that, sometimes as a very diligent clinician, you actually, put your, a bridge device in front of them, or whatever device. We're not talking about Abridge, we're just talking in general.
Yeah.
Patient gives their consent, and if you really want to be comprehensive, you basically let patient talk, right? For a while, then you talk for a while as a clinician. But let's face it, a lot of things that patients say or could be could be just unrelated to particular condition. They express this concern that a lot of this, AI scribe tools, again, not talking about Abridge, just in general,
Yeah.
they would take this patient notes and kind of take it as a sort of at a face value, right? And similarly, the more notes you have, like side notes from the patient, not like main physician notes, the more kind of errors AI scribe would make. And so they have this dilemma, basically. I'm trying to be diligent as a clinician. I'm letting everybody speak. I'm creating a lot of text. But similarly, like volume oftentimes correlates with errors, and then obviously they feel the liability. They're saying, well, I'm trying to be comprehensive, but the more comprehensive I am, the more liable I am. So how does Abridge addresses that concern?
Yeah, maybe one way to talk about it is to think about it in two different ways, like unpack it into two different components. One component is just where is risk in healthcare, which use cases. I think that there's like a 2x2 you can imagine where frequency is on one axis and stakes is on the other. And the high frequency, high stakes axis of that, quadrant of that 2x2 is where we're gonna see necessarily a lot of hoops that companies will need to jump through in order to get their algorithm approved to diagnose, a pneumothorax on a CT scan, to diagnose sepsis in an ICU. There's going to be hoops, or there should be hoops. Depending on how those are implemented especially, there's probably going to be a lot more rigor required because you're directly impacting a clinical outcome. But I think on the other side of that 2x2, there are lower stakes, not zero stakes necessarily, but lower stakes. And when I think about lower stakes, I think less about clinical outcomes, and I think more about financial outcomes. It's still high stakes, but it's not the same as like life and death. Mm-hmm. And so on that side, that's where a lot of revenue cycle workflows happen, a lot of clerical work happens, a lot of like the rote stuff, the scut work as we call it in the hospital happens. And that's where there are so many targets, very, very target rich environment for, agent first sort of products to be built and deployed. And that's where we've decided to live first. Like we haven't run into, other aspects, although, we're starting to move into these new spaces where we can help clinicians feel like superheroes with all the right information and make better decisions. That's a module that we've got live that we'll announce probably next month or GA next month. But, on that other side of the quadrant, the stakes are there, but they're not the same. So what are the different guardrails that need to be in place in order to like ship there? So for us, a lot of the reason I think we've been able to hit a little bit different in the marketplace, you mentioned features like linked evidence, for example, is how we try to hold ourselves to a standard, but then transparently help our health systems understand what governance looks like for us to ship anything. That before we ship any given feature, this is what we did to test that we're not, we're mitigating hallucinations or confabulations. We try to publish papers when we can to put real academic grade benchmarks out there. We'll put white papers out there and we try to make them as unsalesy as possible, obviously like sometimes more successful than others, but we try to be as objective as possible there in terms of here's what we're measuring, here's where we are, we're not perfect, this is what medical term recall looks like, and this is where we're gonna, how it's gonna get better over time, or this is our current deployment of agents that can look for false positives and programmatically remove them, and this is how we're benchmarking with that technology versus what would happen if you use an off the shelf and just sort of like one shot at it. And so I think all of that kind of like adds up over time. This moment is so wild because as we all see, there are new technologies coming out every single day, it feels like. Like the ground is shifting so quickly. Yeah. So the most dangerous thing that I think could happen to our market is that the like health systems out there, whoever the decision makers are out there, that they judge a technology based on where it was even a month ago. Because even in a month, that technology can evolve dramatically. So you sort of need a way, like some sort of rubric, and that's what we call them in the company and ours, like to be able to judge, like where are you, to get those snapshots of like where you are today versus where you were yesterday. So we have we communicate as a company in Slack, and there's no PHI in like Slack, and it's all compliant and everything. But we have a channel in Slack called Love Stories. And so every day we get feedback from end users, so doctors across the country, and they send us positive feedback. We programmatically route it there, or people can enter that positive feedback there. And that means every engineer in the company and every other person in the company can get reminded this is why they came to join Abridge and not OpenAI or Anthropic or whoever else. And so it's a really important channel because it gives everybody purpose. But some of the feedback comes from clinicians who say, like, here's a good one. Like, whatever you did in the last 2 weeks has made a world of difference to the note. The last 2 weeks. Like that kind of feedback demonstrates just how fast like any company can improve. And that's really like, that's how you win right now is we used to take pride that I remember when we first started to like turn on at real scale in 2023, University of Kansas Health System told us that Abridge on Monday was really good, but it was even better on Tuesday and even better on Wednesday and really great on Friday. And like that sort of, that velocity I think is what makes or breaks you. So anyways, back to your original question. Yeah. I think even that specific issue that you described was a real issue in the past, much less of an issue anymore, if at all anymore. And I think some of the current issues that we see today also will go down over time. But it's up to us also as an industry and up to us as a company that wants to build trust to measure that and to be able to demonstrate that to our partners.
Awesome. To follow up on that, and we asked this question, Alex Brown from Nabla as well. Ambient listening solutions are still not FDA regulated. What's your take on this? Should they be regulated at some point? And if FDA actually comes to you, like, say in a year, says, hey, now you need to go through regulations. How hard would it be to go through that?
I think that trust is the actual currency in healthcare. We know that. What's the saying? Like, healthcare moves at the speed of trust. Like all industries maybe move at the speed of trust. And so healthcare especially, it's just first, it's like a top of list item for a lot of people out there for all the right reasons. And so I don't think that we shy away at all from getting all the certifications out there. And at the same time, we're always trying to like, you have to measure the trade-offs between, that example that we just discussed. It could be that there was an issue last week that has completely been, suppressed now with a new model improvement or something we just fine-tuned. And if that's the case, given the way all of these processes work, it's very difficult to, we don't yet have a structure out there that understands how fast this is moving. And we see that also with our research partners. So there's a research partner that I spent some time with who's all about adaptive trial design. And adaptive trial design is so fascinating to me because it might be the kind of trial design that can account for this level of dynamism or change in AI. Because adaptive trials you can sort of measure over time as maybe like the thing is improving, the product is improving, and it still sort of accounts for that. But a lot of the current ways we assess safety, especially the ones that were anchored in hardware, where once you've built something, you're probably built it and it's going to stay the same way for a while. They don't account for this new paradigm. So the moment we need to jump into extra compliance boxes, we will. And we're certainly, we've had the privilege of working with the VA health system, and any number of important privacy, security, compliance boxes that we're checking off there. Those feel very different than I think what you're describing. But the moment I think we get into a space where we feel like we actually need it because we are either more autonomously making decisions for a clinician, which we do not do categorically right now. We are all about simply helping them with superpowers, and that they need to trust and verify all of these outputs in order to get their work done. But the moment we start to like maybe push beyond that is the moment that I will definitely want to make sure that we're figuring out the right way to assess safety.
I don't want to put you on the spot, but if at any point in time regulators gonna come out and say that AI scribes have to put some kind of safety label on their products, like similar to nutrition label we have on food products. What would you have on that label? Is it maybe like word error rate, medical code assignment error rate or something, PHI handling, I guess error, can you think like what's going to be useful for customers to see there?
Yeah, absolutely. I think it's probably a lot of the different metrics that we've built into our LLM judges, into our AI judges that are assessing our technology, like, more automatically, and then also what human judges are measuring for us, so that, we can feel confident before we ship something. So on the speech recognition side, medical term recall, word error rate. There are others related to specific languages, being able to parse across how we're performing across, the scope. In general, whether it's related to speech recognition or on the language side of things or multimodal side of things, I think that there's like this meta label. It's almost like fresh until, like a milk carton, because the world is changing so quickly. So when you actually bottled up this technology matters as much as how long you think it will last. And I think the vertical AI companies that win are going to be the ones who bottle and rebottle again, update the contents of that bottle really, really quickly. So it's like us being able to say these are our metrics on February 1st, and this will last until February 14th, and then here's February 14th new metrics, and this will last until I think that's the actual game, because it's trajectory that matters as much as like any given Polaroid or snapshot. It's so easy to sort of gotcha anybody out there, and on some Polaroid in their past. But already what our product looked like even a month ago feels like a high school yearbook photo for me. I'm embarrassed by it because of where we are right now. Like everything is moving so quickly. So it makes it difficult for the health system customer. But that's where I think do you have the foundational principles to build trust? Do you have the rigor? Do you have the people who can do that? We have someone named Alex Choldachova. She was a professor in statistics for machine learning. Then she went to Microsoft Research. She's a deep statistical, causal inference, and also technologist. She's a researcher, and she's leading a research organization for us called ARC. And she is now leading a lot of the work that we're doing with our health system partners to do the research that we need to do, that they want to publish, but also the research that we need to do internally in order to understand how well we're doing. But it takes those types of people to also be able to, create those fresh until sort of labels. And so, hopefully that wasn't too long of an answer, but.
No, it's a great answer. I think the problem is also standards. Like we don't have, like in food industry, there's a standard. Like what do you put on nutrition? Everybody agrees like what sugar is, what other ingredients. But here, you have all sorts of publications. So you cannot compare a product that got very diligent review in the Lancet or JAMA versus like some white paper, claiming something. So I think that's also kind of part of the consideration. Like, so like as a customer, it could be like really confusing.
It can be very confusing. I think the most bull case for AI is that it allows us, all of us as humans, to live out our values, whatever those values happen to be. And I think that every single company is going to have its own set of values. There could be another company that's maybe simply doing notes that doesn't want to do more than that. There could be a company doing notes that doesn't really think it's valuable to measure word error rate or medical term recall or confabulations, but they think it's more important to measure something else. Delight via some animation that they have in their app. I make stuff up. So, everybody has different values. I think that these values are made explicit and that they're put in front of the customer, the partner, so that they can assess whether or not there's resonance with their values is what matters right now. Because the health system is going to live out their values with AI as well. And they're going to be able to decide, do we like your roadmap? Do we think you're credible? Are you measuring the right way? Do you have the right governance? Are you the right people? Do you have the right leadership? Like they need to understand very quickly is this a company that shares our values? So I think in all of these vertical industries, whether it's legal, whether it's accounting, whether it's finance, whether it's healthcare, we're going to see the companies that win ultimately are going to be the companies that reflect the industry's values. So, when I hear about standards that try to capture, everyone's values, the only thing I worry about is that word capture again. Is it a way for the hegemons, the incumbents, the really big companies, to try to brute force their own values in such a way that makes it impossible for innovators to come in? And you look at the last decades of healthcare technology, the barriers to entry have been just as high as the barriers to exit. So there's so many companies that are in between that don't have to innovate, or can innovate on an 8-year sort of cycle. They can pitch so far ahead of their skis and get away with it because nobody can hold them accountable because there's no competition. But with AI, the barriers have come down with this moment in healthcare, with supply demand shortages and not having enough doctors and all the inflation that we see in healthcare. We want to help make healthcare cheaper, better, faster. We want to be a deflationary force. We think we can do that. That's why we want to build a bridge from providers to payers. We don't want to have anything to do with upcoding things. We want to have to do with delivering better outcomes and getting paid for better outcomes. But for that sort of innovative mindset to get in, the barriers have to be come down. And if we allow, I think, the big companies to set the scorecards because they've got the most influence, those barriers are going to go up again. So I think it's a delicate thing, and I think at least for the moment, it's good for more choice, because then we'll figure out where our values actually settle out.
I know it maybe, we talked about it so many times, but we kind of wanted to maybe set the table, and maybe you can say maybe the final word about all this epic saga. But speaking of epic, there's been so much in the news. In the fall, they had this what they call exclusive partnership with Microsoft on, I guess, DAX, Copilot. Actually, Alex and I went to health conference shortly thereafter. I stopped by Abridge's booth and actually asked that question, you guys are concerned? There are some news that Epic is selling your shares and switching to Microsoft. They're what are you talking about? We still continue, our work continues, partnership continues. And so I don't know, I just wanted to kind of clarify on that. Are you concerned about what's happening with Epic? Are you still working with Epic? Also, they announced a month ago about the AI charting tool. There's always some kind of an announcement going on, so I'm completely confused what's going on with Epic. But obviously they're an elephant in the room, so I don't know if you can give some color or maybe comment on, Epic's positioning or maybe your partnership, how all this news affect Abridge as a company.
Yeah, I remember last year we had a town hall of sorts for many of our health systems to just sort of talk about any number of issues, but this was I think the first and most important issue to just sort of address and speak openly about. And the open discussion, or at least the meat of it, was that there's no risk, in terms of us being able to partner, us being able to integrate, us being able to pull data, push data. That hasn't changed. That's not going to change. And so all of these health systems that we've partnered with, there's no reason for anyone to be worried. And all of the prospective partners that we have in the future, there's no worry there. They're not shutting anybody off. And they would say that. I know that they probably said that, but certainly I think we need to probably repeat that. I think health systems understand that, but so many people on LinkedIn don't. And
like me.
Nobody's getting shut off. And at the same time, for all of the things that you can do with AI, would they want to build with AI? Of course they do, and they are. And I think it's been pretty awesome. And I've been so impressed by the speed with which they're trying to also think about AI and work with their partners to figure out where they should apply AI. And I think what's really exciting, again, this is the bull case for AI right now, is that we're going to see any number of different companies sort of playing together in really positive some ways. We're going to see sort of companies figure out that there is a bigger prize by just figuring out how to work together. To date, our relationship with Epic has felt like that. Like I forget when it was, but in 2023, when they pulled us into the workshop program, we had the opportunity to just sort of think about the future and how can AI actually impact some specific workflows and figure out what those APIs needed to look like and what the workflow should look like. And an incredibly positive sum mindset. And I think they retain that positive sum mindset, and so do we. It could be that we'll start to build things and they'll start to build things that will increasingly abut. But it doesn't impact, I think, the meta mindset that we certainly have at Abridge, which is that like all boats can rise here. Like this is a moment where the mission has to be serving health systems, and it has to be serving clinicians, and it has to be serving patients. There's nothing in our way to do that. And certainly, any number of other companies will do that, but we kind of want that. And I think as an industry, we need that. And I think the more people who are building in any given space, the more pressure. And we have a saying at Abridge, pressure makes diamonds. And so we want that. Like, that's great.
Yeah.
But do you think there's a threat that Epic is going to come to the health system and say, hey, here's our ambient solution, use it for free since you're already our customer? And because of the financial incentive, health system might switch even probably to a worse solution that Epic provides, but because they're providing it as a bundle of their services.
I don't think of it as a threat as much as I think of that as pressure on us to make sure that what we do isn't thought of as an AI scribe. That what we do, that we've been very, very clear that we go millions of miles deep on serving all the different specialties and all the settings and all the spoken languages to get any number of jobs done. And some of those jobs have to do with notes. Some of those jobs have to do with totally different ideas that can really impact an ability to get into a value-based care contract, that can impact the ability to get to better outcomes, that can impact a HEDIS measure, which can impact a STARS rating for a payer, that can impact the ability for a clinician to understand this patient in front of them has inclusion-exclusion criteria for a clinical trial that can save their life. Like what we've got live today and where we're going is differentiated enough. And is personal enough to who we are as people inside of Abridge, that I think the question will be, does the industry resonate with our values more? And we hope it does, and so far so good. But we've got a lot of stuff to build, and it's an exciting time. And hopefully healthcare will continue to make history in adopting more and more AI.
Awesome. To end this interview, you give an impression of a visionary CEO. I want to talk about your vision, not specifically of Abridge, but about the future of healthcare with AGI, maybe whatever that means. Whenever we get there, maybe in 20, 50 years, do you think it's going to change the whole healthcare industry completely? And maybe some examples how?
Yeah, it'll change everything. I mean, we can't even predict what's going to happen in a year anymore.
That's true.
So it's so difficult to sort of push beyond that. But I am as AI pilled as they come. I actually think AI is underhyped. I think valuations are underhyped. I think, for the companies who've got real fundamentals right now. And I if anything, and perhaps what's unfortunate is I think that there's a finite number of companies. There's a smaller number of companies than before. But there is an opportunity for some companies to just create incredible impact by riding the wave. And if a new frontier, sort of capability arises that gets us closer to AGI, if it helps you, then you're riding the right side of this AI wave. If for some reason it's a threat to you, well, you're screwed. You're on the wrong side of this, and you've sort of positioned yourself the wrong way. At least in terms of the next year, 2 years, I think what we'll see, we talked about, low stakes, high frequency workflows. We'll see more and more of that get fully automated. And, then we'll start to see maybe low stakes, high frequency workflows get automated that perhaps, start to touch clinical work. And we're already seeing that in Utah, or we previously saw that in Utah with medication refills. I'm sure healthcare will do this stepwise. Change sometimes it's slow and then it's sudden. And so I think over even this next 5 years, we're going to see a lot of transformation.
I love it. Well, thanks so much, Shiv.
Thank you, Shiv.
Yeah, we were really rooting for you because something needs to change in the healthcare system, specifically for patients in the first place.
100%.
So yeah, best of luck with the bridge.
Awesome. Thank you guys so much. I
Thank
really
you.
appreciate it.
Thank you. Yeah, appreciate it.